So we don't traditionally use kitchen knives for kidney biopsies, but this is a low-budget production. Let's do some teaching. As a nephrology fellow, a common question I get from internal medicine house staff and medical students is, Seabass, how do you decide when to do a kidney biopsy? Of course, as the fellow, my typical response is to say some slick, sexy sentence on the phone, then hang up and promptly call my attending to ask, yo, how do we decide when to do a kidney biopsy? This decision always gets simplified into a binary outcome. Either we say yes and we pursue it, or we say no and we do not. But that binary outcome belies a fair amount of nuanced clinical decision making. Let's unpack that nuance together in 3 parts. 1. When do we go bonkers for kidney biopsy? 2. When do we naysay the needle? And finally, 3. We'll take a sneak peek behind the curtain to meet some of the secret stakeholders involved in the decision-making process. Here we go. We go bonkers for biopsy when the benefits are unequivocal and well-defined. Benefits tend to come in 3 flavors. Let's start with the ones that get the least publicity. First, sometimes we will leverage a kidney biopsy to aid in prognostication. For example, if a patient is entirely new to us and the healthcare system, we won't have labs or previous urine studies to help anchor us in a baseline. Here, tissue can help distinguish between recent versus long-standing damage to the kidney. Second, sometimes we perform kidney biopsies for research purposes to advance global scientific knowledge. For instance, the Kidney Precision Medicine Project has a protocol to perform kidney biopsies on all of its participants. Last, but certainly not least, the biggest benefit for biopsy is for diagnostic purposes. This can translate to actionable therapeutic intervention. That's because histopathologic diagnosis is considered the diagnostic gold standard for undifferentiated kidney disease, both acute and chronic. So, simply put, if you have AKI or CKD and you do not know what's going on, then a kidney biopsy might be reasonable. A specific instance of urgency would be a rapidly progressive glomerulonephritis. A hot kidney warrants a needle with haste. Nephrotic syndrome also usually calls for a kidney biopsy, but you typically have a little bit more time to gather some serologies before committing to getting tissue. Okay, so we explored examples that get us hyphy for the prospect of a kidney biopsy. But what would turn us sour? The simplest answer is clinical parameters that either diminish the diagnostic benefit or magnify the risk. Let's start with risk magnifiers. Clinical situations that magnify the bleeding risk include anticoagulation that cannot be stopped, like recent coronary stent deployment or mechanical valve placement, aggressively high blood pressure recalcitrant to standard pharmacotherapy, structural perturbations to the kidney, like a really big cyst or a minefield of smaller cysts, a blind operator, that is to say, the inability to get a safe ultrasonographic window in perhaps a morbidly obese patient, or finally, the inability of the patient to cooperate. If the patient is floridly encephalopathic, then their diaphragmatic movement will not be receptive to operator feedback. How about magnifiers of infectious risk? So clinical scenarios that would magnify infectious risk include overlying cellulitis in the procedural field, a perinephric fluid collection that we believe to be supra-infected and obstructs the direct path of our needle, or an active infection of the urinary tract like bacterial cystitis. Okay, so bleeding and infection are standard risks of a kidney biopsy that can have situations that magnify those risks. What about a common clinical context in which the benefit of the kidney biopsy is diminished? The classic example is the patient who has kidneys that are already toast. Well-documented, steadily progressive chronic kidney disease, especially late stage 4 and stage 5, might not yield actionable information that will meaningfully change the patient's kidney prognosis regardless of etiology. In Chapter 3, we're going to finish up by taking a sneak peek at some of the secret stakeholders involved in kidney biopsies that are a little bit more complicated. Okay, so when we think about kidney biopsy, some cases have slam dunk benefits with negligible risk. Others have massive risk with no obvious benefit. But many patients are a lot more complicated than that. The young female patient with a past medical history of lupus who presents with oligoanuric acute kidney injury as well as unexplained fevers without a clear infectious source and hypertensive emergency that ultimately leads to catastrophic aortic dissection involving her coronary arteries as well as her aortic valve. And oh yeah, by the way, did I mention she's 8 months pregnant? Does she need a biopsy? In these complicated cases that require higher order diagnostic reasoning, a single clinician can no longer make unilateral decisions about a patient's care. This also includes the consideration of kidney biopsy. Navigating the delicate dance of multidisciplinary stakeholders becomes essential. This is superimposed on patient-centered considerations. What are the patient's goals and concerns, and do they even align with the consideration of performing a kidney biopsy? Then this is superimposed with the cultural context of the institution in which you practice. For example, I train at a center in which we pride ourselves on robust expertise in glomerular disease, so we tend to be more aggressive about pursuing kidney biopsies. The calculus can also change depending on whether or not we're considering doing a biopsy of a native kidney versus a transplanted kidney. Okay, I'm running out of hands to make more layers of the cake. But then this is superimposed on the proceduralist's appetite for risk. Some physicians will back out of a biopsy if the patient sneezes too forcefully, whereas other doctors don't have a problem sticking a needle into a patient who's on VA ECMO. So this is where I'm going to nerd out. It's the act of navigating this rich, multidimensional complexity that makes clinical practice so stimulating. These stakeholders all form layers that coalesce to capture the art of medicine. Let's return to the common house staff question of how do we decide when to do a kidney biopsy? The answer is that it is as much of an art as it is a science. Let's finish up with a quick recapitulation of the 3 main points. The main benefit of kidney biopsy is to gather diagnostic data. The most common indication is for undifferentiated acute kidney injury or chronic kidney disease. The main reason to avoid the biopsy are when clinical situations magnify standard risks, such as unavoidable anticoagulation or acute urinary tract infection. And finally, sometimes the decision is clear-cut, but when it's complicated, it's important to carefully consider all stakeholders. These include human stakeholders like the multidisciplinary team and the patient, as well as psychological considerations like how risk-adverse or avid the proceduralist is. If you learned something today, smash the subscribe button. And if you're an internal medicine resident or a medical student who's wondering how to seduce your consultant into doing the things you want them to do, then check out this video right here. Bye!